Hi all and welcome back. Today we will start a new unit, that is laboratory pathology. I think we will need 2 or 3 videos to do justice to this unit. In this first video or first part, we will discuss urine analysis. Urine analysis serves two purposes. One, it can be used to ascertain the existence of metabolic and endocrine disturbances in the body. Here, the kidneys function normally, but due to the underlying metabolic disorder, the end products of that particular disease can be found in abnormal amounts in the urine. The second purpose urine analysis can serve is to detect conditions that affect the kidney. Here, due to abnormality in the kidney, substances which are normally excreted by the kidney are retained, or substances which are normally retained by the kidney are excreted in large amounts and they are found in the urine. So the point is, urine analysis can serve these two important purposes. Okay, enough of introduction. Let's move into the subject proper. In order to analyze the urine, first it should be collected. In order for the analysis to be meaningful, the collection should be proper. An improper collection may invalidate the result. 3 things must be discussed in collection. 1. The container in which the specimen is collected. 2. The method of collection. And 3. The preservation. The containers used can be glass bottles, disposable containers, or polyethylene bags. The point is, they should be thoroughly cleaned, dried, and should be sterile. Coming to the method of collection, the ideal one is freshly voided, clean catch, midstream specimen. The initial or the last part should be avoided. Ideal one is midstream specimen. And remember, thorough cleaning of areas adjacent to the urethral meatus is very important to avoid contamination from microorganisms. Coming to preservation, ideally the analysis or the test should be done immediately or within 1 to 2 hours of the specimen collection. When the examination is delayed for periods longer than 1 hour, special precautions must be taken. The sample should be refrigerated at 5 degrees Celsius, or preservatives like boric acid, formaldehyde, etc. can be used. And remember, preservatives should not be used if the urine is sent for culture. Just like the collection, the type of sample is also significant as far as urine analysis is concerned. This is because the concentration of urine varies throughout the day depending upon the person's intake of water or due to his activities. The first morning specimen is the most concentrated and has an acidic pH and preserves formed elements and gas. And this sample is ideal for detection of nitrite, protein, and analyzing the sediments. Random specimen is the most convenient, which can be collected anytime, and this is ideal for chemical screening and microscopic examination. Timed specimen is one which is collected in a container for a fixed period of time, that is usually 12 or 24 hours. 24-hour specimen is ideal for quantitative estimation of protein, sugar, etc. 12-hour specimen is for quantitative analysis of cell count, and 2-hour specimen is used for analysis of urobilinogen, glucose, etc. Postprandial specimen, which is collected 2 hours after lunch or dinner, is helpful in detection of glycosuria. Okay, now that we have collected the ideal sample with an ideal method, now let's move on to routine urine examination. Routine urine examination includes physical examination and chemical examination. First, we will discuss the physical examination. The tests included in physical examination are the ones testing the volume, appearance, odor, pH, and specific gravity. Coming to volume, the normal is 1.2 to 2 liters per day, but it varies with the amount of fluid eliminated by lungs, skin, intestine, etc. and also other factors like amount of fluid intake, diet, exercise, environmental temperature and humidity, etc. Also remember, the infants and children excrete 3 to 4 times more urine than adults. When the output is greater than 2000 milliliter, that is 2 liters per day, then it is called polyuria, and this usually occurs physiologically in cold weather and pathologically in conditions like diabetes mellitus. When the output decreases less than 500 ml per day, then it is called oliguria, and it occurs when there is dehydration or conditions like acute or chronic glomerulonephritis. Anuria is when the output is less than 100 ml per day and it occurs in chronic renal disease. Usually, the excretion of urine at night is less than 400 milliliter, but when it exceeds greater than 500 ml, then it is called nocturia. And this nocturia can occur physiologically when there is excess fluid intake or pathologically when there is a reduced bladder capacity, irritable bladder, etc. Coming to appearance, we have to note two things here, color and turbidity. The normal color of urine is amber yellow, and this is due to presence of urobilin, uroerythrin and urochromes. Abnormal color occurs when there is excess of endogenous pigments like hemoglobin, myoglobin, etc. Coming to turbidity, normally freshly voided urine is clear, and turbidity can be due to the presence of chyline phyte or pus. Coming to odor, normal urine has an aromatic odor which is due to the presence of volatile acids, but on standing there is decomposition of urea forming ammonia which gives a strong ammoniacal smell. But if freshly voided urine smells ammoniacal, then it is important to suspect infection by urea splitting organisms such as Proteus. Other abnormal odors include fruity in conditions like ketoacidosis, mousy in condition like phenylketonuria, or rancid in conditions like tyrosinemia. Coming to pH, the normal pH of urine is 4.5 to 8, and this pH reflects the ability of kidney to maintain normal hydrogen ion concentration. Any value below 7 indicates acidic urine and above 7 indicates alkaline urine. Coming to causes of acidic urine, it includes increased intake of vegetarian diet, high protein intake, etc. And coming to causes of alkaline urine, it includes diet rich in dairy products or urinary tract infection. And coming to the methods of estimating pH, the traditional method is the litmus paper test, and the recent methods include calorimetric reagent strip test and use of pH meter. Coming to the next characteristic, there is specific gravity. This denotes the degree of concentration or dilution of urine, that is, the relative proportion of dissolved solid components to the total volume of the specimen. The normal specific gravity is usually between 1.015 and 1.025 in a 24-hour specimen. This is low in conditions like diabetes insipidus, chronic glomerulonephritis, etc., and high in conditions like diabetes mellitus and adrenal insufficiency. The high specific gravity in diabetes mellitus is due to the high concentration of glucose in urine in diabetes. Urine with a fixed very low specific gravity of 1.010 is referred to as isothenuric, and this occurs in severe renal damage. Coming to estimation, it can be estimated either by direct or indirect method. In direct method, instrument called urinometer is used. This is a weighted bulb-shaped instrument with a cylindrical stem which contains a scale calibrated from 1 to 1.060 with divisions from 0.001 to 0.002. The procedure involves floating this instrument in urine and noting the depth to which it sinks. But here you should note that urinometer is calibrated for a specific temperature which is indicated on each instrument, and if the test is done in a different temperature, then temperature correction should be done. There is a change in the specific gravity of 0.001 for each 3 degrees Celsius above or below this calibrated temperature. So 0.001 should be added to the reading for each 3 degrees Celsius above the calibrated temperature, and the same way 0.001 should be subtracted for each 3 degrees Celsius below the standard temperature. Indirect method uses a refractive index, and it is done with the help of instrument called a refractometer. Moving on to chemical examination, it includes examination of proteins, sugar, ketones, bile and bile salts, and blood in the urine. Coming to examination of proteins, usually very small amount of protein alone is excreted in urine. Excretion of increased amount of protein in urine is called proteinuria, and this is one of the single most important indicators of renal disease. Marked proteinuria is when there is excretion of proteins more than 4 grams per day. Moderate proteinuria is when there is excretion of protein to the level of 0.5 to 4 grams per day, and minimal proteinuria is less than 0.5 grams per day, and all these occur in different renal diseases. Coming to the types of proteinuria can be accidental when there is contamination of urine with blood, pus, vaginal discharge or seminal fluid, or it can be functional or physiologic proteinuria. The causes of physiologic proteinuria include excessive exercise, exposure to heat or cold, fever, emotional stress, excessive ingestion of proteins, etc. The underlying mechanism in all these conditions is a renal vasoconstriction. There is also something called postural or orthostatic proteinuria. Here, proteinuria occurs when the subject is in upright position and disappears when the individual lies down. The third type is organic and renal albuminuria. In this type, proteinuria or albumin passes from blood into the urine through the walls of the kidney tubules, and this occurs in kidney disorders. Coming to tests for detection of proteins, the first group is semi-quantitative precipitation tests. The tests include heat and acetic acid method, sulfosalicylic acid method, and nitric acid method or Heller's method. Here the protein is quantified from 1 plus to 4 plus precipitation. 1 plus is equivalent to 10 to 30 mg per deciliter, 2 plus is equivalent to 40 to 100 mg per deciliter, 3 plus to 200 to 500 mg per deciliter, and 4 plus 500 mg per deciliter or more. If the urine is alkaline, it should be made acidic by addition of a few drops of 3% acetic acid. And remember, the urine must be clear before testing for albumin. Coming to the procedure of tests, coming to the first one, heat and acetic acid method. Here, urine is taken in a long test tube and the upper portion is boiled over the flame. If proteins, phosphates or carbonates are present in the urine, a white cloud develops. Now, 1 to 3 drops of glacial acetic acid is added. This removes any phosphate precipitation, and if there are carbonates, they disappear with effervescence. If the cloudiness persists after addition of glacial acetic acid, then it is definitely due to albumin. In sulfosalicylic acid method, equal volume of 3% sulfosalicylic acid is taken along with urine. It is mixed and allowed to stand for 10 minutes. The amount of turbidity is estimated. In nitric acid method or Heller's test, 2 to 3 ml of concentrated nitric acid is taken in a test tube, and about 5 ml of clear urine is poured down the inner side of the inclined test tube so that urine forms a layer over the nitric acid. A ring of white precipitated protein will form at the interface, and the amount of the precipitate is estimated. There is another semi-quantitative precipitation test, which is calorimetric reagent strip test. This is based upon the ability of proteins to alter the color of some acid-base indicators. The indicator used here is tetrabromophenol blue. In this test, the protein is determined by dipping the strip into a well-mixed uncentrifuged urine and immediately comparing the resultant color with the chart provided in the reagent strip bottle. You will come across calorimetric reagent strip tests in most cases while determining other constituents also. The procedure is more or less similar, only the indicator used changes. Coming to the next group, that is quantitative 24-hour protein group. Two methods are commonly used for 24-hour protein estimation, that is SBACS and Offert's method. In both these methods, the protein is precipitated with the help of picric acid. In multiple myeloma, the urine of patients show increased excretion of low molecular weight globulin called Bence-Jones proteins. This Bence-Jones protein is soluble at room and body temperature but precipitates upon heating to 45 to 60 degrees Celsius and then dissolves on further heating. So gradual heating of urine sample to the boiling point is the simplest screening method for Bence-Jones protein. When present, the precipitate will first appear and then redissolves as the urine is further heated. There are other tests also, like acetic acid test, where 1 ml of acetate buffer is used. The mixture is placed in 56 degrees Celsius water bath and heated for 15 minutes. Precipitation indicates the presence of Bence-Jones protein. If the tube is heated further, the precipitation will redissolve and it will reappear again when cooled. Another test is toluene sulfonic acid test. Here, toluene sulfonic acid is used and precipitate appears within 5 minutes. When only small amounts of Bence-Jones protein is present, then electrophoresis can also be useful. There is no point in me reciting the detailed procedure of each test, which is available in the textbook. You can easily read that. So I will only describe the salient features. No point in repeating every procedure step by step. Okay, let's leave proteins here and move on to estimating sugars in urine. Glucose is the sugar most commonly found in urine and it appears in renal glycosuria, diabetes mellitus, etc. In renal glycosuria, the blood glucose level is normal, but tubular reabsorption of glucose is below normal. Whereas in diabetes mellitus, it is a pathological state where there is marked elevation of blood sugar level. Coming to the tests, first we will discuss the qualitative test for sugars in urine. It includes the reduction tests. The first one is Benedict's qualitative test. Remember, this test is not specific for sugars. It is affected by any reducing substance in the urine. Here, urine is added to Benedict's reagent and heated. It's cooled down and the color is noted. The color varies from blue through green to yellow to orange to brick red. No change in color denotes negative. Cloudy green denotes 0.5% sugar. Yellow to orange precipitate denotes 1% sugar. Orange to red 1.5% and brick red 2%. As I told you, there can be false positives when there are other reducing agents in the urine. Another test is Felling's test. Here the reagent used consists of two solutions, solution A and B. Solution A has copper sulfate and distilled water, where solution B has sodium hydroxide, sodium potassium tartarate and distilled water. Both solution A and B are mixed, boiled, and a few drops of urine is added. The color change is noted. The color change is similar to that of Benedict's test. Another test is colorimetric reagent strip test. This test is based on double sequential enzyme reaction. One enzyme, glucose oxidase, catalyzes the formation of gluconic acid and hydrogen peroxide. A second enzyme, peroxidase, catalyzes the reaction of hydrogen peroxide with potassium iodide chromogen to oxidize the chromogen to colors ranging from green to brown. This test is specific for glucose, and no other substance excreted in the urine is known to give a positive result. Apart from glucose, there can be other non-glucose reducing sugars also. These include lactose, which appears in lactating women, infants, etc. The test used is Rubner's test. I will not go into the details of the test. You can read that from the textbook. Another sugar is fructose, which is present in the urine of patients consuming large quantities of fruit and also in hepatic disorders. This can be distinguished by Selivanov's test. Pentose is a rare sugar usually seen in congenital disorders. It is detected by Bial's test. And galactose is a sugar found in urine of infants with galactosemia. Sometimes it is also seen in adults who consume large quantities of milk or other lactose-containing foods. Other tests for reducing sugar include tablet test. This consists of a self-heating tablet which determines the presence of reducing sugar by reduction of copper. And another test is Ozone test. Enough of this, let's move on to ketones. Ketones in urine is called ketonuria. Whenever there is inadequate carbohydrate in the diet or defect in carbohydrate metabolism, the body metabolizes increasing amount of fatty acids. When fatty acid utilization is incomplete, the intermediary products of fat metabolism appear in blood and urine. These intermediary products of fat metabolism include acetone diacetic acid, otherwise called acetoacetic acid, and beta-hydroxybutyric acid. These are called ketone bodies. These are seen in conditions like diabetes mellitus or severe starvation. The tests include Rothera's test, which is a test for acetone and acetoacetic acid, ferric chloride test, which is for diacetic acid, Hart's test, which is for beta-hydroxybutyric acid, and reagent tablet test or acid test, which is for acetone and acetoacetic acid. Along with this, there is also calorimetric reagent strip test, where the agent used is sodium nitroprusside buffers. Moving on to blood in urine. Blood may be found in urine in the form of red blood cells or blood pigments alone. Hematuria refers to red blood cells in urine, and this occurs in various renal disorders, trauma to urinary tract, etc. Whereas hemoglobinuria refers to presence of blood pigments alone in the urine, and this occurs in conditions like hemolytic anemia, malaria, etc. The tests for detection of blood in urine include microscopic examination, where sediment obtained by centrifuging is examined under the microscope and number of red cells per microscopic hyperfield is reported. Another test is benzidine test. Here the principle used is heme acting as a catalyst when hydrogen peroxide is mixed with benzidine. Calorimetric reagent strip test is available here also, and the reagent used here is tetramethylbenzidine and buffered organic peroxide. Coming to examination of bile in urine. Bile is excreted in urine as bilirubin, bile salts, urobilin and urobilinogen. And excess bilirubin appears in urine in conditions of hepatocellular disease. The tests used for the estimation or identification of bilirubin include Foam's test, Mellin's test, Faucet's test, and of course calorimetric strip reagent test. The strip reagent test here is based on coupling of bilirubin with diacetized 2,4-dichloroaniline in a strong acid medium to form a brown-purple azobilirubin compound. The color of this compound ranges from various shades of tan. Urobilinogen in urine is increased in conditions like hemolytic anemia, malaria, etc. and it is decreased in obstruction of bile duct or antibiotic therapy. The test for detection of urobilinogen include qualitative Ehrlich's test, qualitative Schlesinger test, and of course calorimetric reagent strip test. The principle of calorimetric reagent strip test here is p-diethyl aminobenzaldehyde in conjunction with a color enhancer reacts with urobilinogen and porphobilinogen in a strongly acidic medium to produce a pink red color. And coming to the test for bile salts, it is called Hayes test. Here, flowers of sulfur are sprinkled on the surface of urine, and if bile salts are present, they sink to the bottom. This is because the bile salts lower the surface tension. Coming to our last section, there is microscopic examination of urine sediments. The examination of urine sediment provides information on presence or absence of renal disease and type and activity of the renal lesion. Evaluation includes both qualitative and quantitative evaluation of the sediments. First, let's discuss qualitative evaluation. Qualitative evaluation is more reliable when the urine is freshly voided and it is concentrated. Here 10 to 15 milliliter of urine is taken and centrifuged at a standard speed, usually 1500 to 2000 rpm for 5 minutes. The supernatant fluid is poured off and the sediment is resuspended in 1 milliliter of the same fluid. The resuspended sediment is placed directly on a microscope slide and covered with the cover slip. The slide is first examined under low power magnification to locate the casts and elements that are present. After the entire slide has been scanned, a further examination is done under high power magnification in order to identify specific cell types, crystals, elements, etc. While examining under low power, the light should be reduced and the condenser should be lowered, otherwise the cast will be missed. Coming to the examination of normal sediment, it contains unorganized and organized elements. Discussing unorganized sediments. Unorganized sediments are crystals of various substances present in the urine and they vary with pH of the urine. Crystals in acidic urine include uric acid and urates, which appears in disturbances in uric acid metabolism and fever. Amorphous urates appear as red granules and uric acid crystals vary in shape and are yellow-brown in color. Calcium oxalate crystals are seen in diet rich in tomatoes and spinach. They are envelope or dumbbell shaped. Cystine crystals are hexagonal refractile plates and they are seen in cystinosis. Leucine crystals are slightly yellow, oily-looking spheres with radial and concentric striations, and they are found in liver disorders. Tyrosine crystals appear in the form of fine needles arranged in concentric sheaves with a marked constriction at the middle, and they are seen in patients again with liver disorders. And finally, sulfur crystals are seen in patients taking sulfonamides. Coming to crystals in alkaline urine, this includes ammonium magnesium phosphate, otherwise called triple phosphate crystals. They are colorless and appear as coffin-lid, feathery or leaf-like forms, and they are often seen in stones in kidney. Dicalcium phosphates are colorless prisms arranged in stars and rosette pattern. And calcium carbonates are seen as amorphous granules or colorless spheres and dumbbells. Ammonium biurates are yellow spherical crystals which are often covered with fine or coarse spicules. Moving on to organized sediments. Organized sediments include cas, red blood cells, white blood cells, epithelial cells, bacteria, yeast, parasites, spermatozoa, and artifacts. Urinary cas is an important topic, and urinary cas are formed in tubules and is composed of proteinaceous material. Since they are formed in tubules, they take the shape of tubules, so they are cylindrical in shape with round or broken ends. They are mostly of uniform diameter but vary in length. Practically, all cas have hyaline matrix, but they may or may not contain inclusions such as desquamated cells. The cas are usually named after the inclusions contained in them. Discussing the different cas present in the urine, they include hyaline cas. These are colorless, semi-transparent and occasionally refractile cylinders, and they are seen in fever, emotional stress and strenuous exercise. Granular cas are cas containing large or fine granules embedded in coagulated protein. They are usually seen in pyelonephritis and chronic lead poisoning. Epithelial cas are formed of fused desquamated tubular cells, and they are seen in diseases where there is damage to tubular epithelium like nephrosis, amyloidosis, heavy metal poisoning, etc. Red blood cell cas are seen in hematuria and are found in pathological conditions like acute glomerulonephritis, renal infarction, etc. White blood cell cas are seen in patients with acute glomerulonephritis, nephritic syndrome or pyelonephritis, and they are composed of pus cells. Fatty cas are embedded with numerous fat globules, and they can be stained with special stains like Sudan 3. These are derived from degenerating cells. Waxy cas are broad because they are formed in collecting tubules, and they are composed of homogeneous yellowish material and have a refractile outline, and they are seen in chronic renal disease. Apart from cas, red blood cells can be seen. This is usually in conditions like trauma to kidney. They appear as pale, light refractive biconcave discs. White blood cells or pus cells can also be seen. They are usually with segmented nuclei and granular, and they are seen in urinary tract infections. A marked increase in epithelial cells is seen in urine in conditions like destruction of tissue in the urinary tract. The cells seen include renal tubular cells, bladder epithelial cells, or squamous epithelial cells. Moving on to quantitative evaluation of urine sediment, otherwise called Addis count. Addis count is a quantitative measurement of the excretion of red blood cells, leukocytes and cas in the urine during a 12-hour period. Here, a 12-hour urine specimen is taken and formalin is used as preservative. One drop of sediment is transferred to blood counting chamber and counted in a manner similar to WBC count. WBC count we have already seen in clinical pathology section. Yes, this is also similar to that. Bacteria can also be found in urine in urinary tract infection, but here special care must be taken to obtain a clean voided midstream urine specimen under strict aseptic conditions. First morning urine sample is better, and the test should be ideally done within 1 hour. If that is not possible, the specimen should be refrigerated at 5 degrees Celsius immediately. Remember, no preservatives should be added. Bacteriuria is considered significant when there is presence of more than 10 power 5 bacteria per milliliter of urine. The bacteria present can be either gram-negative or gram-positive. The common ones include Escherichia coli, Proteus species, Streptococcus faecalis, Staphylococcus aureus, etc. Yeasts are seen in urinary candidiasis, but here they are sometimes confused with red blood cells. But remember, they differ from red blood cells by being round, colorless, variable in size, and frequently show budding. Spermatozoa are frequently seen in urine following nocturnal emissions or sexual intercourse. They have oval bodies and long, delicate tails. They may or may not be motile. Chyle is seen in conditions like filariasis, when the lymphatics in the wall of the bladder or kidney may rupture, and lymph with its fat droplets escapes into the urine to give a milky appearance. And as I said already, fat can be stained with Sudan 3. Okay, enough of urine analysis. I think we have done more than enough. We will discuss more of laboratory pathology in our next video. As usual, I have provided PDF notes in the description. For further guidance, you can mail me. For more videos, don't forget to subscribe the channel. Until we meet in another video, thanks for watching. Bye.